sounds crazy because there's no muscle, but it does contract. And the reason every case doesn't end up like those on the right is that, and I'll start this again, the reason every case doesn't end up like that is the zonules eventually stop the rexus from contracting any further. And so if you have weak zonules circumferentially, the rexus will just keep contracting. So there's several techniques for this, but I make an oblique cut and then I re-tear the rexus. And this is actually something that with practice you can get very good at because it's the same principles as the capsulorhexis. But now I know exactly how big to make it. I don't have the convexity of the anterior capsule, and um, I basically don't have the same sort of fear because if somehow it goes veers outward, you just leave it there. Don't rotate the lens, but you've effectively made this less likely to contract. So, yes, you can polish the capsule. Yes, another thing you could do is make little tiny little radial cuts, almost like relaxing incisions. Don't go way out to the periphery, but just think of that CCC edge as a sphincter. So here's another case with pseudoexfoliation, and you'll see I don't worry about the size here. I just want to complete the rexus. But then after I place the lens in, I go back and I re-tear it. Now, I'm a little compulsive here. I'm actually tearing out to the edge of the optic. You don't have to do that. You can simply make relaxing incisions if you're not comfortable with it. But the point is, don't leave it small, or you will see it contract. And with pseudoexfoliation, that's going to happen. Uh, so what we're doing here is widening it, but also removing some of the lens epithelial cells on the back surface of the anterior capsule. And what happens when you do this and you go back and you look just a month later or a few months later is the rexus is quiet. It has not contracted. And so this technique to me has really helped because I no longer worry about making the perfect size capsulotomy when I'm making it, when it's challenging. I deal with it at the end when the IOL is in place. All right, this next video is a case where I had a round rexus. I put in a three-piece monofocal in the bag, and that round rexus became oval. Now, why would that be? Why would a round rexus suddenly become oval when I put in this three-piece lens? Well, there's point pressure from the haptics up here and up here, and there's no counterfixation 90 degrees away from the zonules, and so the rexus ovalizes at that point. And when I see that, I know that, the zonules are on the weak side. So can I put in a CTR? The answer is yes. And I decided to do that. So here I'm injecting it. Now it's going in the opposite, sort of against the grain with the direction of the haptics, but that's okay. And you can see how I aim the injector way to the left, but I want you to see what happens now. That oval rexus became round. It's perfectly round now. And I include this video because it shows what the mechanism is of the CTR. And that is to distribute the forces circumferentially for all 12 clock hours. It's even throughout the 360 degrees. And that's what the CTR does. So it isn't so much increasing the zonular strength, but it's now redistributing the forces. Uh, and so that's the kind of the mental image you have of what a CTR is doing. All right, now look at this. Right here, I'm starting the rexus and I press down and I see this little halo sign. And what that halo sign is, you can see this is pseudoexfoliation. There's a bleb to your left. That halo sign means that I'm depressing rather than incising the anterior capsule. And that could be for one of two reasons. Number one, it could be a dull needle, or it could be that the anterior capsule is not taut because of diffuse zonulopathy, allowing the capsule to sort of be indented with this sharp needle. This little halo sign, let's watch it again. There it is. And so, whoop, finally I get through, and then I start my Rexus. So, but remember that sign because the question is, you have pseudoexfoliation. What are the, or maybe a history of trauma, and then here I'm putting in a CTR. Notice where I'm pointing the injector. I'm not pointing it right in the middle like an IOL injector. I'm pointing it way to the side because I know that the CTR, as it opens, would otherwise try to displace the capsular bag. And so by pointing it to the side, I avoid that. All right. So, um, and there we go. So the signs when you have let's say you have, we'll start this over again, a history of trauma, pseudoexfoliation. How do I know if the zonules are weak? Well, obviously, if there's gross pseudophacodenesis at the slit lamp, you know you've got a problem, or gross phacodenesis, I should say. Another warning sign is a really shallow chamber in an eye that has a normal axial length. In other words, it's not a super hyperopic eye, but you see a shallow chamber in an otherwise normal axial length eye, or maybe one side has a much shallower chamber than the other. Then I know I'm going to have weak zonules. But other than that, it's the CCC that is my first sign because that's kind of the first time I touch the lens. And so it's kind of a zonular stress test is when I do the capsulorhexis. And that's when I truly know whether I've got zonulopathy. I think you've all heard of Brian Little's capsulorhexis tear rescue technique. Here you see his publication from 2006. And it's when you, and these are images from his original paper. When you feel that the rhexis is about to escape, you grab it and pull it backward from the opposite direction and then redirect it. So I'm going to show my own case here in the white cataract. And so as I'm tearing it along, there's a point here where it seems like I no longer have control over it and it wants to veer out. And I like the analogy that someone came up with of a dog on a leash. You know, you're guiding the dog on the leash, and you have that sense of when the dog wants to pull away and go in the wrong direction. So, what Brian Little taught us to do is to counter, it's kind of counterintuitive, but you grab the rhexis flap, you pull it back in this direction. And what this is doing is it's tightening the leash. And once you tighten the leash on the dog, then you can control and kind of get it back in the correct direction, which I'm doing here. And once I feel I've turned it inward, I flip it over and I continue. Let's see me do that. So here I'm pulling this along and kind of, right about there, I felt that it was going away from me, so I pulled backward. Why is it that I'm having trouble with a mature cataract like this? Well, you release the milk the minute you incise the capsule. I can see some of the milk over here, but there's still cortex liquefied behind the nucleus, and it continually wants to push the nucleus forward, and that's why the tear wants to go radial. So I pull back, and now I turn inward. See how I'm shortening and tightening up on the dog leash to get control over it, and then I can move again. So I'm kind of erring on the smaller side, so I have a little margin to recover. Oh, there it goes again. It wants to go out. So I pull backward, and then once I have it firm, I start turning it inward once I have control over it. So this isn't zonulopathy here, but it's a different cause. But we use this technique, of course, all the time. Now, look at this. Here's a problem. The tear veered all the way. I'm doing my rhexis here, and I'm going counterclockwise, and it veers out. Unfortunately for me, the pupil's very wide, so I can actually still see it. But that means I have to pull the capsule flap toward the very top of the screen. Let's see if I can succeed at doing that. I pull upward, and I can see the little folds in the peripheral capsule here. Um, and I'm right up against the zonules because this is such a widely dilated pupil. You can see the folds here. That's another sign of zonulopathy when the peripheral capsule has folds in it. But using the principle and trusting in it, I'm able to round this off, and there we go. And this is the path you see I took with that capsulotomy. Now, this is a younger patient. What do you see right there? What is that? That's a little bit of the halo sign, right? And so again, is it because it's a dull needle and it's depressing rather than incising the capsule? Is it because the zonules are weak and the capsule isn't taut? Well, here it's due to elasticity. This is a teenager, and so again, it's elastic, so it wants to stretch, and I have trouble incising it. I'm also going to have trouble tearing it. That's why it's hard to do the CCC in a pediatric case. And you can see here, here's the Brian Little maneuver, just like we showed you, but for a different reason now. It's not a white cataract or zonulopathy. It's a very elastic capsule, all right? And then once the IOL is in, but notice I made it small because the key is to complete it. All right, now here's a case. Look right here. Um, it's like the capsule's elastic, but this is an 87-year-old patient, so it can't be that. And this is due to zonulopathy. So when I see, let's show this again. Now the key is what's really happening is as I'm pulling on the flap, I am seeing the posterior, the peripheral capsule moving. When you do a CCC, you don't think about it, but the peripheral capsule is always held still by the zonules. It's like you're trying to tear a piece of paper and you use your left hand to steady the paper, right hand tears the leading edge. And it's the zonules that are responsible for keeping that peripheral capsule immobile. So if you see the peripheral capsule moving, with the capsulotomy, it means you've got zonulopathy. Look at the folds there. So I call this in my textbooks pseudoelasticity because it looks just like that sort of pediatric case with an elastic capsule, but this is a thick capsule, and it's because of zonulopathy that we've got this happening. So these are the signs to me that I've got zonulopathy, and I may need to consider capsule retractors. Here's a case where I'm doing the INA, and to my horror, I suddenly realize I'm not stripping cortex. I've grabbed the nasal rhexis and I've suddenly pulled it inward. And so I've created a zonular dialysis temporally. So I have a little question for you. Let's go to question A, and I want to know what you would do in this situation. So if we can have question number A. So the anterior capsule is aspirated. You've caused the nasal dialysis. What's your next move? Do you continue cautious IA, either coaxial or biaxial? Do you insert a capsule tension ring and then proceed? Do you place the IOL in the bag and continue? Or do you place iris retractors and then continue? So please vote now. This is not something that happens infrequently, but it doesn't happen frequently, but in this case, we've pulled it, and now we've got to finish the case. So we'll see what you all voted for. So overwhelmingly, 67% are saying let's put in a capsule tension ring. All right, so I'm going to do what you guys suggested, and here goes the capsule tension ring. So again, I know I have to be careful. So I'm actually trying to bend the ring to do this. And look at what happens now. I see the edge of the bag. Whoa, I'm seeing the edge of the bag way over here. There's no zonules at all. Holy cow. So, all right. So this is not as I thought it might be, maybe 3, 4 clock hours. This is like 8 clock hours. So now that I've put a capsule tension ring in, this is an old video, but I'm trying to show my best teaching ones what happens. So when I grab the cortex now here, and I'm trying to strip, and yes, you can, try tangential stripping, which recruits more counterfixation from a broader area of zonules. But I want you to watch while I'm actually grabbing the cortex to your left, you'll see the entire bag is moving. And why is the entire bag moving? It's because the CTR is distributing my cortical stripping forces to the entire bag, weakening the rest of the zonules. So even though I'm pulling here and I can't get the cortex because it's trapped, you see how the whole bag is moving? So we'll show that again here. So this is a case where I didn't appreciate until I put the CTR in how bad the zonules are. And I'm lucky I didn't completely dislocate the bag by inserting the CTR. So again, look at the right-hand part of the eye and how the entire bag is moving. So the CTR has done two bad things. It's trapped the cortex, and it's basically weakening all of the rest of the zonules as I try to strip the cortex. And so the CTR, which here I did what you would have done, the CTR was a bad thing to do. So the point of this is that, well, it kind of makes sense if I've got maybe um, you know, 8 healthy clock hours and 4 bad clock hours, because then I can recruit the zonules in the 8 healthy clock hours to support the bag. But if I've got 4 healthy clock hours and 8 bad clock hours, the opposite, then the CTR is a bad thing because it's doing the opposite of what I want it to do. So it doesn't always make sense. And so I want you to really visualize this video the next time you're thinking about putting a CTR in early. Now, by the way, now I know why I stripped the bag with my INA tip. It's because the zonules were so awful here. And so normally, again, we don't realize it, but we might just have our INA tip kind of gently skim across the back of the anterior capsule. We probably, get close to aspirating it a lot, but the zonules anchor it and they don't allow it to kind of get aspirated into the ionate tip, so we don't end up stripping the capsule along with the cortex. But because I had such weak zonules, it became very easy to aspirate and strip the anterior capsule in this case. All right, some things I could have done. I could have used this Morcher Henderson CTR that Bonnie Henderson designed. You see it's scalloped so that the edges don't capture the cortex or pin it to the fornix. But capsule retractors, popularized by Dick McCool, I think were the better thing to do. And that's what I eventually had to do to get out of that mess. All right, now here I'm trying to put in a CTR and I'm bending it, but look what happens right there. I can see the peripheral capsular bag. Can you see it? Right along here. So here, this happens to be a case of a dead bag syndrome. And as I put the CTR in, it's actually, there's no zonules there. So it's a similar case. So the question is, well, what could I have done differently? Maybe iris or capsule retractors. But this is a wonderful device. I have no financial interest. Dr. Shimawaki in Japan developed this spiral CTR injector, and you have the traditional hook on the left that's going to get the eyelid in and retract it. And on the right, you have a fixed post. So this is available through Corsa Catena. And so as we pull this CTR in, I'm simply going to hook the eyelet onto the edge. And now watch what happens. I go into the eye, and Now the CTR is bent by that hook. And what happens that you don't realize is normally when you inject the CTR, it's the capsular bag and the zonules that bend the ring for you. And so that is going to be a problem if I have diffuse zonulopathy, as you just saw. So I use this all the time now. And here I've got these capsule retractors. I've got a lot of hardware in the eye, and I have to negotiate around that. But I'm able to get that through and pop it off. And so it's the principle, and that avoids pushing there. So this is his video, the standard CTR injector on the left. And I think the main thing is realize this, that when you inject the CTR, these are the forces. So you see with the Shimawaki spiral CTR injector how there's no pressure placed on the capsular bag. So really ingenious invention of his. All right, I've got this last piece here, and I know that I have pseudoexfoliation. I know I have a dense nucleus. I can't aspirate this with the INA tip. And I just have this feeling that the posterior capsule wants to come up to me, so I'm putting my chopper underneath the phaco tip. So I'm watching the phaco. I'm watching. Oh, right there, I grabbed the posterior capsule. All right, I'll do that on replay, even though I know I have to be careful. I just for a minute moved that so I could see, and I grabbed it, and there I have, you can see a nice primary posterior capsulotomy. This patient will never need a YAG capsulotomy. Let's go to question B, and I want to know what you would have done in the situation when you've got the final fragment to aspirate. Do you lower, do you really lower your vacuum setting more? Do you place a second instrument behind the phaco tip? Do you inject OVD into the bag or implant a CTR? Or what about putting in the IOL and then getting the last tip? So please vote now. So, let's say you're in that situation, you don't have a lot of epinucleus. What do you do to avoid aspirating the posterior capsule, the phaco tip, and as I did just there, causing a posterior capsule rupture? So we'll see what everyone says here in a moment. So a lot of people are doing different things, but I think all of these are reasonable. And yep, putting an IOL might have helped. Injecting OVD into the bag, kind of tied for the lead. All right, so here's another case, and let's see what I would do. All right, and this is what I should have done. I'm injecting a dispersive viscoelastic into the capsular bag, and I'm not just moving the pieces forward, I'm filling the bag. I'm using a dispersive because it stays where I put it, and it acts to stretch the capsular bag. So the problem is that normally your settings that allow you to do that safely in a normal case are not going to work safely here because you don't have centrifugal zonular tension. The posterior capsule is not on stretch. So it's like a sail on a sailboat. It wants to luff. It wants to get sucked up because it's not taut. And so if the zonules aren't there to make it taut, you could put a CTR in, but as we just saw earlier, what that's going to do is trap the cortex. But if I put in a dispersive viscoelastic and I fill the bag, the dispersive stays where I put it, and it actually is putting the posterior capsule on stretch, in taking the place of the function of the zonules. And you can see how it stays where I put it, and it keeps the capsule back while I aspirate those last fragments of the cortex. Here's another case where I'm going to, okay, there's the epinucleus. I'm going to stop. I'm using, in this case, Viscoat, and I'm actually filling the bag. And look how it holds the posterior capsule back. So this is a really important technique. And you see the viscoelastic there. Now, oh, here's another problem. And I think you've all seen this. You're pulling on the cortex, and the posterior capsule is rising up and coming with the cortex toward my tip. And I'm going, holy cow, what's the problem here? Is this just sticky cortex? The cortex is sticking to the bag? Well, no, it's the same issue. The zonules are not strong. They're not providing counterfixation, and the peripheral capsule wants to come up toward the tip. And so I have to be really, really slow motion careful because the posterior capsule wants to come. So what should I do? Look at how I struggle here. This is highly, highly risky, highly dangerous. So I'm going to stop and inject a dispersive viscoelastic into the capsular bag. Now the posterior capsule is on stretch. The OVD does not trap the cortex the way a CTR does. And you can see now I'm able to strip this away, and you can see how the dispersive stays where I put it. And now I put the CTR in after I remove the cortex because it won't get trapped at this point. All right. Now, we've talked a little bit about capsule retractors. These are from microsurgical technologies. They bear my name, the Chang modification. I have no financial interest. And they are different from iris retractors. They're longer, so they're meant to support the fornix. And you are not trying to stretch the CCC mouth. So the one thing you don't want to do is make them so tight that you stretch the anterior capsule, because then when I put the phaco tip in and the entire bag moves back, that'll tighten up and I can tear the CCC here. But these are my artificial zonules. If I have really weak zonulopathy that I can tell during the CCC, I put them in before I rotate the nucleus. You do need the capsulorhexis. So one of the things that helps is that when I'm out there aspirating this fragment, it's a soft nucleus, it keeps the peripheral capsule from being aspirated. Remember I showed you that case where the peripheral capsule was aspirated by the INA tip. It supports the bag in the anterior-posterior direction, but it gives counterfixation, especially when I want to rotate the nucleus. Now, let's put all this together. I see a halo sign. I see some movement of the entire capsular bag. So I know I've got zonulopathy. I see folds in the anterior capsule. And I put in my capsule retractors before I hydrodissect and rotate because I want the counterfixation. I employ phaco chop to minimize stress on the capsular bag. And I do all the tricks in the book. You can see there's a bleb to your right. In this case was pseudoexfoliation. This is a case from 2005. It's an older case. I'm really super slow motion. And here's, just as I was showing, the posterior capsule wants to follow the cortex. It doesn't want to separate because the zonules are not taut. So I have to go super careful. If I was doing this case now, 20 years later, I'd put dispersive viscoelastic in the bag. But I succeed. I get this eventually done. I like putting in a three-piece monofocal if I'm doing a monofocal, even with the CTR. You notice I'm bending the CTR with my second instrument to minimize the force on the capsule, kind of Shimawaki idea. These haptics have more compressive force, so a three-piece, unlike a single piece, kind of also puts more pressure on the capsular bag. And even though the rhexis isn't that small, I'm going to do this technique where I enlarge it. Again, I don't think most people would do this, but I could have made little relaxing cuts in the edge of the anterior capsule just to prevent the sphincter-like effect. So here I've kind of shown you a case where I did all of those things. Again, this case was 21 years ago. And then I make a mistake. And guess what that mistake is going to be? I want to see what happens if I shake the eye. So I shake the eye and it moves. And I have a weak bag. This is pseudophacodenesis, and the entire bag is moving. All right, so let's go ahead and show question C. I want to know what you would do at this point. Would you just leave it alone? Would you uh, try to suture the CTR to the sclera, which is what I might do if I'm coming back 8 years later and I see the bag moving? Would you suture the haptic to the iris? Would you move the lens to the sulcus? And if so, would you suture the haptic to the iris, or would you exchange it for an iris claw or AC lens? So please vote now. All right, so pseudophacodenesis, I mean, if I saw this patient in the office and they said they had cataract surgery 6 years ago, I'd say, well, we better take you to the operating room because if we don't do something now, eventually this is going to dislocate, subluxate, and eventually end up on the back surface of the retina. So what would you do now? So a lot of people would suture the CTR to the sclera or move it to the sulcus. Some would exchange it. So we have a real broad distribution of thoughts here. So what I ended up doing is I'm thinking, yeah, I cannot leave it this way. There we go. So it's loose. So I'm going to try to move it to the sulcus. Now this is a little hard to do because this is the lens, the optic is posteriorly angulated, right? The haptics are angulated anterior. And I also enlarge the rhexis. So the only way to do this is I have to bring the haptics into the anterior chamber because the only way I can know I'm just under the iris is to go from the anterior chamber into the posterior chamber with the haptics that I'm doing here. And I got to be sure I'm not in the bag because otherwise I'll be back where I started. I don't want both in the bag. And so I'm dilating the sulcus and I got both in the sulcus. So now what do I need to do? Well, who wants me to shake the eye to see what happens? I'm going to shake the eye and the lens does not move. So why do I call this one of my best teaching cases? This is the index case that taught me something very important because although I'm not showing you a series of 20 cases, I am showing you uh, a case where I put the same lens in the same eye in two different places, in the bag and in the sulcus, and you see what a difference this makes. So the conclusion is in the sulcus, I have additional 2-point fixation of the haptics. So I'm not relying just on the CTR. And that is what stabilizes the bag against this movement. And so I call this technique of putting a three-piece lens in the sulcus belt and suspenders. I'm not relying only on the zonules, and I'm not relying on the CTR, my belt. I'm also using the haptics against the ciliary body as my suspenders. Here's another case. Here's the lens. It's moving. You see, I'm shaking in the eye and it's moving. And so I've got the same dilemma. So I say I can't leave it there. The CTR is already in there. And I'm going to try to pull this into the sulcus. But to do that, I have to first bring it into the anterior chamber. And then one haptic at a time, I pull it in, dial it into the sulcus. There I go. And now I'm actually capturing the optic. And now I move it and the lens is stable. It's not moving any longer. So now you've seen two cases in which this is the case. All right. Now here's a case where I have a traumatic zonular dialysis. I've got my capsule retractors. I inject the CTR. I'm aiming my CTR tip to the left because I want the CTR to open to my right. And I want you to watch the CTR and see what happens. It's going to start to bend like an archery bow right there. It's bending. So what I have to do is I have to make a snap decision. Do I continue? And I stopped. All right. So let's see that again. I have to decide, do I keep pushing right here or do I stop? Because I'm encountering resistance. So I decide to stop and I put more viscoelastic in, dispersive or a cohesive. And now I'm going to grab the eyelet and do my own version of the Shimawaki injector to get past that troublesome area. Once I'm past it, it flows. So you have to understand the dynamics of the CTR and not force it. You also, if you've got capsule retractors, you leave them in when you inject the CTR. And that is why uh, you'll see my capsule, and you leave them in because they're your artificial zonules that are giving you counterfixation. And you can see the Chang modification of these capsule retractors. The loop is much smaller, so it's impossible to thread the CTR through the loop as it would happen with the first generation. So now I've got this big zonula dialysis, and I'm going to put a three-piece monofocal in, but I'm going to put this in the sulcus because of that previous case. I'm going to capture the optic, and I'm going to keep the haptics 90 degrees away from where it's weak. In order to, if I'm going to capture the optic, but I have an intact posterior capsule, this is different from when you do it when there's a PCR. I need to remove some of the viscoelastic from behind the optic that's in the bag. I don't have to get it all, but I need to remove some of it because if I have too much viscoelastic back there, it cannot get out when I buttonhole the optic, and it's going to push the optic forward, and I'll have, right there, I'm aspirating it. Okay, and then I capture, and I capture it here. Now, why did I leave the haptics this way? Well, I want the area of the intact zonules, to basically be holding them there. But it's not in the bag. So in the sulcus, if I place a lens in the sulcus, I have to worry about the IOL rotating. And it tends to want to rotate, and then the haptic will go through the zonule dialysis nasally. If I was in the bag, I would probably have the haptics pointing toward the zonule dialysis because the haptics, kind of like a CTR, are pushing outward and resisting contraction. But here I'm in the sulcus. And if I don't capture this optic, it will rotate. So that's the benefit of optic capture in this specific case. All right. So what are the benefits now of optic capture? It prevents rexus contracture. I'm going to get good centration if my rexus is centered. It prevents that rotation through the dialysis. I don't have to adjust the IOL power. All right, we're going to show you one more case here. I'm putting viscoelastic in. This is a rock hard lens. There's my rexus. I'm starting, and now I'm going to start tearing it. And what I'm looking at is the entire lens moving just as I am pulling on this capsule. So I'm going to pause here and ask you what you would do. Okay, so let's have the final question D for you to vote on. So we've got a rock hard lens. We've stained with trypan blue. We've done our initial rexus. I've just completed it now. And would you proceed with cautious phaco? Would you insert a CTR or capsule retractors, or perhaps both a CTR and retractors, or would you convert to a manual ECCE? So go ahead and please vote now. So I've got a clear corneal incision. I will tell you that normally in a case like this, I will always do a retrobulbar block because I don't know if it's going to be a longer case. I don't want to have to deal with a patient who's not able to cooperate. And if I need to convert, I am ready to because I have the appropriate anesthetic. We'll see what all of you decided to do in this case. So I'm seeing that about a third would convert. Most people would use some combination of a CTR capsule retractors before phaco. So I'm going to basically do the last, and that is uh, I'm going to end up converting. So here I'm seeing so much movement. And I mean, you have to ask yourself, what am I really gaining with a phaco, with the mature lens? So I'm converting, and I have to cut the edge to convert to a can opener. And then I'm going to abandon my temporal clear corneal incision. And you have a choice. You could do, I'm now superior. You could do a scleral pocket and do a manual small incision technique. But for many of us, you're not that familiar with it. Just go in the limbus. Don't worry about number of sutures at this point. You're just trying to get this nucleus out of this blind eye without retained cortex, without retained nucleus, without a PCR, vitrectomy, and without enormous endothelial cell loss from phacoing that rock hard lens. And so I put viscoelastic again above it. This is by manual expression, and you'll see how much phaco energy and time that would have taken. And I'll just pause. I'll just sort of pause right. Um, just watch this part again. And, you know, so I don't think we show this enough. I don't think we do this enough, because we're just so, our ego is so tied to that small incision. But if we get through a case like this with an intact posterior capsule, posterior chamber IOL, and a cornea that's not going to have edema for 2 months, we're heroes. So, just a temporary suture, and, just use my same three-piece IOL. I don't have to fold it. And then I put in plenty of sutures, and that's, basically, let me finish the case here. Notice I didn't suture the temporal clear corneal incision, but here at the end, I'm back temporally. So I've placed my sutures, I move back temporally, and I use that to remove the viscoelastic, and then it's self-sealing. I bring down, use my occult to bring that down. So I think this is something that we should do more often, and not try to be a hero there. So again, these are the 6 strategies that I showed you this morning, and this will be archived on the CyberSight website so that you can go back and look through that again. In terms of IOL fixation with pseudoexfoliation, if there's truly no zonulopathy, I don't think you need to put in a CTR in every case, but certainly I would not leave the rexus too small, and I showed you how to do that. If there's any sign of zonulopathy at all, even though you got through the case, I'd use a CTR. And if the bag is loose, you can consider some of these excellent sutured elements, Sione or Malyugin ring, and Ahmed CTS. But I showed you something that if you don't have experience with those, maybe you don't even have them in your operating room, you can always put a three-piece lens in the sulcus with optic capture, and that works. If I'm using a sort of a premium lens, an EDOF, I tend not to do multifocals with pseudoexfoliation because the greater risk of tilting or decentration later on. But if you are doing an EDOF or a toric lens, even though the zonules look healthy, I will put a CTR in those cases, because just in case that lens does subluxate or become wobbly, it's easier to suture a CTR and preserve that lens. All right, so I'm going to stop sharing my screen there, and we'll go ahead and move to the Q&A here. All right, so please talk about lens iris diaphragm retropulsion syndrome. So that is reverse pupillary block. This is a term coined by Bob Sione, and you see it in myopes, because the iris is thinner and it likes to adhere to the anterior capsule. And so once you put the INA or the phaco tip in, the irrigation doesn't go beneath the edge of the pupil into the posterior chamber. It stays in the anterior chamber, propels the entire lens iris diaphragm backward, and you stretch the zonules. If you have zonulopathy, I think that's the point of the question. You want to avoid that. And the way you avoid it is you lift the iris edge up before you go to position 1. So you go into the eye in position 0 with your INA or your phaco tip. You lift the iris up. A lot of people do it with a second instrument. I actually lift it up with the tip of the phaco or the INA tip, and that will then you go to position 1, and the irrigation fluid goes above and behind. Um, Femtocapsulorhexis, of course, is an option, and you're sort of more assured to have it. Um, Many of us, I don't use femto myself, so it's never an option for me, and it's certainly fine to do that. I will say that there's one benefit of a manual rhexis, and it's what I alluded to. You know if the anterior capsule is taut. You know if the zonules are weak. So if you've done a femto, you don't really know, and you kind of need to decide before you rotate the nucleus and hydrodissect if you want to put capsule retractors in. Um, if once you've hydrodissected, it's a little harder, much harder actually, to put in capsule retractors because you can't see the edge of the CCC. And it's not just that you want to hook it, you don't want to stretch it. And that's why I think it's important. Capsulorhexis size and lens epithelial cells, um, again, you can, that was my point earlier. Don't leave it small. You'll have a greater burden of lens epithelial cells, but even if you polish the undersurface of the anterior capsule, I find that with a small rhexis, it wants to contract. And you cannot get all the lens epithelial cells. If you don't want to vacuum the undersurface of the anterior capsule if you have pseudoexfoliation, because remember what I showed you, that how easily it is to dehisce zonules when you aspirate the bag. Um, Nuclear prolapse is certainly a reasonable technique, but you have to have, it can't be a giant nucleus with a small rhexis. So if the nucleus is softer and it's not that big, then that might work. I personally prefer phaco chop because the phaco tip is anchoring the lens. And so in both cases, what we're saying is we don't want to do maneuvers in the capsular bag that require zonular counterfixation. So nuclear prolapse is an option, but beware because often we've made the rhexis small, the pupils smaller, and the nucleus could be larger. So you have to be very cautious about prolapsing the lens. Now, what I do think is a great technique, we have diffuse zonulopathy, a traumatic zonulopathy, is to chop the nucleus in half, and then as soon as it's small enough, it could be heminuclei or it could be a quadrant, pull it out of the bag, and you're doing it in the sort of iris plane, so equidistant from the posterior capsule and the endothelium. But again, you're trying to take your maneuvers out of the bag, and I think that makes a lot of sense. If you don't prolapse the entire nucleus, yeah, maybe if you've chopped in half, try to get the heminuclei out, not your normal phaco chop technique. So the question of CTR injection routinely, I think I addressed. I would do it if I'm doing a premium IOL. I would do it if I think that the zonules are on the weak side. Your best IOL choice, um, well, if you're putting the lens, so I like a three-piece monofocal when I'm doing a monofocal in pseudoexfoliation. I'm going to put in a CTR. I feel that the three-piece, it does have more compressive force, so it's kind of reinforcing the CTR. Maybe that's not as critical. But these are cases, again, where, so if I wasn't, let's say I have pseudoexfoliation, I decide, the zonules seem fine. I don't think I need a CTR here. It's a monofocal IOL. I would put in a three-piece monofocal rather than a single piece. And what that means is if that lens ever did subluxate or I had pseudophacodenesis, I now can go back and suture the haptic, which is not so easy to do or maybe contraindicated with a single piece. Um, I also like the three piece for the reason that I showed you that it gives me the option to put that lens in the sulcus and get that fixation. So I guess the advice would be um, go into surgery with at least a three-piece IOL as your backup, to have that. Now, manual injector versus forceps guided, I think do whatever you're comfortable with. If you do it manually, I think Brian Little came up with this fishtail technique. You can Google it and look what that means, but you're basically bending the CTR and then introducing the bent angle of the CTR into the eye. And we're all doing what Dr. Shimawaki was addressing, and that is the fact that the CTR being inserted itself is going to stretch the bag and displace it. Um, when I do put the lens in the sulcus, I do still put a CTR in. You're never 100% sure that you can capture the optic. That's my goal. I'm usually able to, but there have been cases where the entire bag is so weak and it just wants to move away from me, I can't even capture it. And if you don't put a CTR in, it'll crumple up. A CTR in general, I think, just gives you lots of options. It gives you an option to suture the bag later. So that's a good question. In those cases where I'm putting a three-piece in the sulcus, I would still put a CTR in beforehand. Um, CTR zonular stress at the leading eyelet. Yes, I think these are points. The injector angle I addressed. You aim way to the side. You inject slowly. You don't want to see it bend. You have to fill the bag, distend it with OVD. If you put in capsule retractors, leave them there. They'll stabilize the bag as you inject the CTR, and that's how you reduce CTR-induced zonular stress. Um, in Indonesia, we only have a single piece, or the sulcus three-piece lens is difficult to find. Can you use a single piece acrylic lens and put it in the sulcus? Unfortunately not. You're going to get iris chafe, and you're going to get UGG syndrome. So you can really never put a single piece IOL in the sulcus. So there you're going to have to put a CTR in. But I would talk to some of the manufacturers and see if there's any way that you can get backup consignment of that. And so that's a good point. This is not always available. If PCR happens during cortical cleanup, you will have to address that. It's kind of a different a lecture that we would do there, but I'm going to just say for the purposes here that think about that strategy of a dispersive when you are trying to aspirate cortex and you're having trouble with the posterior capsule coming up. to you. Use the card in the case of zonulopathy. Okay, what's the best phaco technique for zonulopathy? Um, I'm partial to phaco chop, but you're going to do what you're comfortable with. This is not the time to learn. But remember, when you're doing a lot of sculpting, um, especially with that dense lens, uh, what is holding the nucleus? Something has to counterfixate it. It's the bag and the zonules. So one of the benefits of phaco chop is you are impaling the nucleus with a phaco tip, and that's what is fixating the nucleus and giving you counter fixation. Um, would you put the lens in the case of diffuse zonulopathy if it's a single piece? Okay, we addressed that one already. If there is pseudophakic disease, I put it in the sulcus. Shouldn't we do an optic capture to control for effective lens position? Ideally, yes. So when you do the three-piece lens in the sulcus, I had a slide that showed the four benefits of optic capture. Sometimes it's too loose and you can't do it. Okay, so then you're just going to leave it in the sulcus. But I want to emphasize the point: if you're every time you've done optic capture in the past, typically it's because you have a rent in the posterior capsule, and the viscoelastic leaks into the vitreous cavity, and it will not cause an IOP spike, and it will not displace the lens forward. But if you capture an optic with the lens in the sulcus with a capsular bag that's distended with OVD, you are trapping the viscoelastic in the bag. It will push the entire lens forward. You'll see a myopic surprise, and you'll see the lens right up behind the iris. So you can still get out of it by yagging the posterior capsule. But I showed a technique where I just went in there and aspirated some of the viscoelastic. Yes, you could, in a case of such a terrible bag, take everything out, and then you're back to IOL fixation without a capsular bag and whatever intrascleral haptic fixation technique you want to use, you can do. But I think in the case that I showed you, moving that lens to the sulcus worked so well, and that is a technique, my gosh, that was 20 years ago. And so I have used that technique hundreds of times, and I don't see all the patients with long-term follow-up, but I personally feel that saved so many eyes from having late bag dislocation as a result of that. And I can't show you long-term follow-up in every one of those cases, but clearly I showed you those two eyes with the same lens and the same eye in two different locations. Clearly, there's far more IOL support when those haptics are in the sulcus. So clearly, your chances of avoiding late subluxation, dislocation of the bag are improved by putting the haptics in the sulcus. Um, so when you put a three-piece lens in a bag with a dialysis and it's 3 clock hours, yes, you can have the haptics in that direction because what it's doing is it's like a CTR. It's pushing the bag outward, reducing the need for zonular counterfixation. But if you have a CTR, I would do that first. But if you don't, then a three-piece in the bag aiming toward the area of weak zonules is a good idea. When I converted to an extra cap, did I put a CTR in? No, you don't need to. That's an interesting question because back when we did everybody with an extra cap and a can opener, we never saw bag IOL dislocation, all those pseudoexfoliation, weak zonule cases we did. So there's something about, of course, the CCC acting like a sphincter that I think again causes that. So in that case with the extra cap, because I did a can opener capsulotomy, I simultaneously took away any risk of the capsule contracting and late bag IOL dislocation. Malayugan ring, helps with a pupil, so you can certainly do it, but it doesn't help with the zonules. But it brings up a good point. What if I've got pseudoexfoliation? Well, so many times they have a small pupil. So some people like the Malyugin ring because then I still have to make potentially 4 stab incisions for my capsule retractors, and so I don't have as many punctures. The one problem with the Malyugin ring is you can't convert to an extra cap. So uh, you can also put in iris retractors and then go in between them with the capsule retractors. So now you've got 8 paracenteses. So you're right. I think more often than not, if we're going to do phaco, we'll use a Malyugin ring. And so that's a helpful question. Um, how does posterior zonulopathy alone present and can be managed? I don't think we really distinguish between anterior and posterior zonulopathy. Yes, the anatomy is such that some zonules insert more anteriorly than others. Um, the bag just crumpled. There wasn't any issue during phaco. Hard to know what's happening there because when we're in there maneuvering in the eye, that's when we really understand what the bag is doing. But you can create zonulopathy by your surgical maneuvers themselves. But I guess if the bag is crumpling, that's usually happening because the IOL is in the sulcus. So maybe I didn't understand that question. For extra cap suturing, um, yeah, the shoelace. So if I'm doing, let's say I'm going temporally, and I still place anterior chamber lenses. I trained at a generation where we have so much experience with those, and I feel that if they're properly sized, they're really well tolerated. All techniques have complications, whether it's a Yamani or an anterior chamber lens, if it's not done correctly. If it's done correctly, I think they all work, and the literature will support that. But let's say I do a bag IOL exchange and I place an AC lens through a temporal limbal incision. I will do a running shoelace because it's temporal. Gravity is not going to tend to stretch that incision and it's small. But if I'm doing an extra cap, if you do a shoelace, um, it's not going to seal quite as well. And if you do it with a superior incision, you're going to have a huge drift against the rule with tons of astigmatism. So the benefit of interrupteds, yes, it takes a little longer, but if you're going to do an extra cap, the benefit of an interrupted suture is there's more compression of the tissue, and so when you lose the tensile strength of that nylon suture, there will be less drift of that incision causing astigmatism. Um, Lower IOP settings with the platform. Yeah, I do not think that the IOP is loosening the zonules. We are doing so many things in the eye that the infusion is really not, I think, a major factor. And if you try to play with your settings and get too cute and fancy by lowering your infusion, I think the problem then is you're going to have more surge. And the same, when I showed that fragment that I was aspirating, I was already using my low setting that I get away with all the time for the last fragments. But the point is, those settings are determined for when I have normal, posterior capsule tension. And those safe settings that I would normally use for the epinucleus may not still be safe when I have diffuse zonulopathy and the posterior capsule wants to come up, toward me. So I don't really like the idea of lowering infusion settings. If you may want to lower your vacuum setting, um, um, but I'm basically talking here about gravity based. If it's pump based, again, you might consider that the real. I think the question is getting to the earlier point about reverse pupillary block, LIDRS, lens iris diaphragm retropulsion syndrome. And that's what really pushes back on the lens and creates zonular stress. That's why when we do it in a myo and you go to position zero, the patient, feels the pain because of the stretch of the sclera, and you are pushing the zonules back. The entire iris, I'm sorry, the lens iris diaphragm is moving backward. And so, yes, I think that is very um, traumatic to the zonules. So rather than lowering the IOP, I think your best maneuver is to prevent lens iris diaphragm retropulsion syndrome, and I addressed that in the talk. Yes, three-piece lenses can be flanged, and you can do that if you're comfortable with that. That's certainly an option. Um, we didn't cover um, suturing a Sione ring or a Malayugan ring. That's also an option. So clearly, those are going to give you fixation in ways that don't require um, the zonules to do all the work. Um, but there was a paper in JCRS in the last year that showed that when you place an IOL, even in the bag, if it's anterior, the haptics may ride over the ciliary body and fit in that sort of space just behind the iris, and you're getting actually sulcus fixation. So I think that what we're doing when we place the haptics in the sulcus is we're actually getting haptic fixation. It's just not with the suture. It does mean you want the haptics to be not on the pars plana, but anterior as possible, so they kind of sit in the sulcus. Manual small incision for a rock hard lens with zonulopathy. I think all methods of extra cap are going to be obviously very friendly to the zonules compared to phaco. And whether you're comfortable with M6 or the ECCE that I showed, do what you're comfortable with, and you're going to have a better chance of preserving the lens capsule. Do I modify my chop technique? Um, well, I think that horizontal chop in general, I think all chop techniques, if they're done correctly, are going to relieve you from stress on the capsular bag and the zonules. But I do think horizontal chop is a little easier to do because what happens with vertical chop is as you get to smaller and smaller pieces, like a quadrant and so forth, it's hard to vertically chop. Even a heavy nucleus is hard. So that's why horizontal chop or switching to horizontal chop at that point is an excellent technique. Um, Single suture over continuous suture for closure. Yes, if you're doing manual small incision and M6 and you're doing temporal, a single suture could close it. You're really thinking when you're doing the suturing, what is the effect of the incision going to be on the corneal astigmatism? So temporal is nice, but in the case that I showed, if you've already made a temporal clear corneal incision, it gets very difficult and messy to try to then put on top of that an extra cap incision. So I tend to go superiorly and get a fresh plan. Suture will lose its tensile strength pretty quickly, and the tissue won't have fully healed, so you're going to get stretching and against the rule drift in that case. Um, why is a one piece generally avoided in the sulcus? Okay, so a single piece acrylic will have very thick haptics with sharp edges to the anterior optic and to the haptics. It's also too short in the sulcus. So it will be mobile, and those sharp edges will rub against the back surface of the iris called iris chafe. You'll not only get pigment dispersion, but you'll basically get um, eventual erosion into the iris stroma. You'll hit little blood vessels. You'll get microhyphema. The pigment dispersion causes glaucoma, and the iris contact, the uveal contact, will create iridocyclitis. So UGH stands for uveitis, glaucoma, hyphema, and it's that triad. A three-piece is angulated. It's longer, so in the sulcus, it's less likely to move around. Now, obviously, there can be eyes with a huge sulcus, and then even movement still can occur. But there's more separation from the optic and the iris. There's more clearance. It does raise one question, is that not all three-piece IOLs are the same. The J&J AR40 Sensor has a rounded anterior edge, and that's the one I would put in the sulcus. If you have optic capture, it doesn't matter with the rhexis, but if it's sitting in the sulcus, you want a rounded edge to the anterior capsule. Liliana Werner at Moran had a series of more than 2 dozen cases of iris chafing with a three-piece in the sulcus when they used the Acrosoft Alcon model, because it has sharp anterior, it has a square edge on the anterior surface. It's not rounded. And so it's that sharp square edge that creates the iris chafing. Um, if some sticky epinucleus is there. Yeah, uh, I used to think that the tissue itself, this patient has sticky cortex or this patient has a sticky epinucleus. It's basically my failure to hydrodissect. Hydrodissection, the main thing it does is it loosens it loosens the epinuclear capsular adhesion, and that's why we can rotate the nucleus after we hydrodissect. We're really rotating the entire epinucleus, and the reason it's important is that when you go to aspirate the epinucleus, if you didn't hydrodissect well and that plane has not been created, then the epinucleus adheres to the capsule and it's harder to aspirate and it's much more difficult. So this is all about hydrodissection beyond the scope of this lecture, but that's what hydrodissection is before. If we convert to an extra cap, um, uh, any three-piece lens will be fine. You do have more options. We used to have single-piece PMMA. We used to have larger lenses with 14 millimeter overall length with 13. For these cases where we want to put a lens in the sulcus. I'm in the United States. We no longer have the Star three-piece lens, which was 13.5 millimeter overall length. So all of our three-piece IOLs are now 13 millimeters long, and so that's what we end up using. And now we're hearing that even in some countries, such as Indonesia, we don't even have three-piece IOLs available, which is really a shame. Um, so this person puts a CTR in high myopia cases before putting the IOL. I don't really think that's necessary. I don't do that. The CTR is basically preventing the CCC from contracting, and helping with IOL centration. So I don't uh, understand quite what the mechanism would be for high myopia. Fluid misdirection is possible. I think sometimes it's overdiagnosed, but it would be shallowing of the chamber. And the um, you're basically having a shallowing chamber and you're trying to diagnose what's going on. So it can occur, but in my experience, it is not that common. Um, in terms of surgical videos, I mean, I think CyberSight is kind enough to basically archive our session today. But basically, if you, my textbooks are available still in some places. Those are, I know no one people, the textbook industry is also um, not really robust now, and many people are closing them up. Slack closed their textbook session, and so it's a problem now. But that's one of the areas where textbooks excels. They can really walk you through that. Well, I think we have gone over our time, but we've had a good half an hour session of answering questions. I want to thank everyone for tuning in from wherever you are around the world. I'm always impressed with CyberSight's reach. And I also just want to thank Orbis and CyberSight. This um, uh, annual Crandall conference is really the idea of Chief Medical Officer Hunter Turwick, who himself is a teaching giant, and his commitment to education is what drives the entire team at CyberSight, and they do. No one does it as well as they do. So continue to follow what they do, and it will improve. They will continue to improve everyone's education. So thank you for joining, and have a good rest of the weekend.